To run that real. But I'm sick of girl, goody. Watching me up and tell them not to got the woody. Front way, back way, cut the came on up and show me. Virgin, them walk give me and me up to took it. Hot girls out the road, I say them see me. And I tell me, say them up something for give me. How much some of that them on him about the Jimmy. Them a promise and I tell me, say you feel me. But the promises are compared to a fool. So cool. I don't know, so that man up the roll, this cool. But I bet them just like a fool. Welcome, everyone. I'm just getting everything started. Welcome. I see you. Still I got to stick to my girls like glue. And I'm not play number two. All I know this time is to get in jail. Need a lot of cheese up in my head. And another damsel in my bed to run that real. Girl, I love you. Welcome. We are grabbing our daily help. Priscilla, I see you. Welcome to the conference, Priscilla. I see you. Piles, I see you. Miss Lennon, thank you for joining. I see you. Marcia, welcome on in. Thank you for joining. Hold on, let me post it to my story. And let me send out to our speakers. As you guys are all coming in, we are grabbing our daily heart me. We are liking the live and we are reposting. Thank you. I don't see who that is. Just give me a minute. Let me let me see if any of my speakers are here. Welcome, Marcia. I see you liking the live. I see you. Kyles, that was you. Thank you so much for the glasses. I don't know what it's called. Thank you so much for that. Hold on. I'm trying to get my speakers up here. Dr. Low, I see you, Dr. Lolo. Okay, the mogul social worker, I see you. I just sent you your request. I see you, ma'am. You can go on mute until we're ready to speak, okay? Let me send it out. Okay, perfect. I see they just... Oh, wait. Nayland, I invited you by accident. Hold on. Okay, Dr. Trish, I just sent your invite. Okay, we getting this. Okay, welcome everybody. We'll give everybody a minute to come on in. We'll go on mute for now. And we'll give everybody a minute to come on in and then we can all come on camera. Welcome, ladies. I'll see you guys. In a one night, then we know she's a hoe. If she a clean up the whole of the neighborhood, then we know she's a hoe. If she a walk on herself from hotel to hotel, we know she's a hoe. If she a one night stand, take everybody, man, I don't know that we don't know she's a hoe. She's a hoe. The hide again, cause everybody know she's a hoe. She's a hoe. First, I miss my top and then everything I know. She's a hoe. She's a hoe. Okay, y'all will send out. We'll give it another minute or so. Yes, I do have new stickers. I see you, Mickey. She no ready for the video. Your buckle shape no ready Welcome, 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 everybody. I can't. You see, once you get into this conference mode and to send it out, it's such a hassle. So my moderators will do what they do best. Thank you so much, everybody. Welcome, welcome, welcome. I appreciate all you guys being here. Wait, 1, 2, 3. Hold on, we missing somebody. Hold on. I'm about to get started. We're missing a guest. Hold on, hold on, hold on. She's not here yet. 1 second. We can't start without her. Let me send it to her. I think I sent it to her. Okay, I think Dr. Trish went to go call her. I see you sharing out, Dr. Lewis. I appreciate you. Miss Nike, I see you. Welcome on in. Miss Jackie, I see you. Welcome on in. Aaron, I see you. Welcome on in, sir. Dr. Trish, I assume you went to go tell her, right? Because I sent it to her. Everybody just joining on in, thank you so much. We are grabbing our daily heart meet and we are liking the live. We are grabbing our daily heart meet and liking the live. The nurses stat, I see you all the way in the UK. Thank you so much for joining. I did not know you were going to be able to make it this late. I appreciate you being here. I'll see you. Dr. Henry, welcome on in. I see you. Welcome on in. We're just waiting for one more speaker. We're just waiting on one more speaker, and you know I got my tunes going. You get the new clocks, the daddy. I wish color that, I no party. Are you alone at the style, the daddy? The Queen to England, no backyardy. When you get the new clocks, the daddy. Miss Nene, I see you. Thank you so much. I appreciate you. Are you alone at the style, the daddy? The Queen to England, no backyardy. Real bad man, no muggle in a shot. Real bad man, no muggle in a shot. Real bad man, no muggle in a shot. Thumbs up in the chat. How is the audio? Thumbs up in the chat. Now that I brought everybody up, thumbs up in the chat. Is the audio good? Real bad man, no muggle in a shot. Straight jeans, cut off footpaths. Everybody have the arms, so me get me. The audio is good? Perfect. Okay, thank you. Perfect, thank you. Okay, I see the thumbs up. Thank you, everybody. We're just waiting on one more guest. Sit back, relax. We almost there. You know we all minorities, so we know we don't start on time. Hello. Can I get a hello in the chat? We all minorities. We can't start. We don't start on time. Miss Carolyn, I see you. Welcome on in. Dr. Lowe, exactly, but we always get the job done. You're right. I appreciate you, Mikey, for being here. Steph Shika, I see you. Welcome on in. Welcome on in. We're just waiting on one more guest, but as we wait, we are grabbing our daily heart, we liking the live. And once our other guest comes, we will all get started. The short stuff, I see you. Welcome on in. Thank you for grabbing my daily heart meet. I appreciate you. I appreciate you. I see you, short stuff. I see you, Miss Nike. I see you, Mikey. Ooh. 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 I'm trying to keep it professional. You know, good evening, Steph Shika. I see you. Maggie, I see you. Welcome on in. Okay, Dr. Trish with her heart meet. I see you, Dr. Trish. The short stuff, I always got the tunes going. Dr. Henry, thank you so much for using the stickers. I see you. Miss Jackie, I appreciate you. Papo, I see you. Welcome on in. Thank you for joining. Oh, the short stuff says she's amped up. Yeah. Dr. Henry with the stickers. I see you. Dr. Lewis, thank you so much for sharing out the live. I appreciate you. wait. I need to hear that mix again. Hold on. Yes, so we're gonna get started. And when she come in, she come in. Because I don't want to keep my people waiting. Because we got gems to drop. Damn, that's the one sticker I forgot. Friend greetings, welcome on in. As everyone is coming on in, we are grabbing our daily heart meat. We are liking the live. We're waiting on one more guest to hop in the live so I can bring them up. I appreciate you. Thank you so much for grabbing your daily heart meat. Mikey, I see you sharing out the live. I appreciate you. Dr. Trish, is she coming? She just commented under one of my photos, so I know she on TikTok. I wonder if her phone died. I appreciate you. I see you. We're waiting for Health Educator Lou. Health Educator Lou is who we're waiting for. She was just commenting on one of my photos. I'm so special. I'm so special. Once I see her name pop up, we going. We ready. I appreciate you guys all sharing out the live. I appreciate all the gifts. We just getting started. Friend greetings. I see you reposting the live. Wait. Oh. Dr. Henry, I see you with the popular votes. Braids in the boots. Welcome on in. I'm glad you're here. I'm glad you made it. We're waiting for one more guest, and then we're gonna get started. Okay, we just have one more guest. 7:45. We're gonna get started. If the guest is here, the other guest is here. If not, we're gonna get started because I know we ready. I know we want these gems because I got gems to drop. Okay, so 7:45. We're gonna jam on till 7:45. Vanessa, welcome on in. Welcome on in. I see you. Braids and boots, welcome. I see you. Thank you so much for being here. I see you. Papa, I see you with the heartbeat. Thank you so much for being here. I appreciate you. 7:45, we're going to get started, okay? Thank you for grabbing your daily heart meat. Everyone, we are grabbing our daily heart meat. We are liking the live and we are reposting. 7:45, we are going to go ahead and get started. I see you, Dr. Henry. Dr. Henry, you like my new stickers? I appreciate you, Dr. Henry. Dr. Lewis, you definitely got to come on down to Jamaica. You definitely got to come. Yes, Dr. Trish, that's the sticker you made for me. Dr. Lewis, I'm glad you're here too. Okay, we're gonna go ahead and get started. Hold on, let me just bring back up. Let me send this invite. Okay, perfect. Okay, you guys, we're gonna go. You got kicked out. You back now. We're gonna go ahead and get started. Everybody, when Health Educator Lou joins in, I will bring her up. I don't want to keep everybody waiting. My amazing public health professionals, can we come on camera and can we hear some audio? Dr. Trish.
Hello.
Okay, the mogul social worker. I see you. No, I hear you. Can you see us?
I can.
Okay, we can't see you. Are you okay? Perfect. There you go, ma'am. First class RN. First class RN. Can we hear you? Can we see you?
Hi. I'm getting it set up. Give me just a
Okay,
second.
Dr. Trish, can we hear you? Can we see you, Dr. Trish? Okay, welcome, Dr. Trish. I see you. We'll give first class RN a minute to get started. I see you guys are using my stickers. I appreciate you. Posh History Professor, welcome on in. You guys, welcome to the Minorities in America, a public health issue conference. This is important. Okay, this is important, Dr. Trish. This is important. Miss Sinedra, this is important. The mogul social worker, this is important. So everybody, thank you so much. Before we get started, thank you so much for being here. The mogul social worker, I'm new. To you. We met. Your page came on my feed and I fell in love with your content. I fell in love with your message. And when I was planning this conference, I said, I definitely have to reach out to you for you to share your perspective over on this topic specifically and your subject matter expertise as it relates to your professional experience. So we're going to get into each and every one of you. But everybody, first and foremost, thank you so much for being here. Thank you so much for taking the time to step into the Minorities in America, a public health issue conference. Okay, so before we get started, that's a brief introduction. This is going to be about you guys and sharing all of you guys' acquired knowledge and skills and expertise as it relates to these topics. Okay, so can I have each of you just give a brief introduction of who you are, what you do? We'll start with you, Dr. Trish, then Mr. Nader, and then the mobile social worker. Okay, what obviously we all know this is social media, so whatever names you don't want to drop, you don't have to drop. You could just use context clues. But Dr. Trish, we'll start with you. Oh, you're on mute.
I missed that one. Sorry about that. Hi, everybody. My name is Dr. Trish, and I have been a health educator for over 20 years. I worked as a community health educator in many different types of institutions, schools, community centers, universities, health centers, YMCAs, you name it, helping people with their overall health and wellness, managing or preventing. And currently, I am a professor at a university and I teach predominantly public health courses, health policy and management, intro to nutrition, and community wellness. I also help graduating students with their capstone, project papers, master's thesis. I teach environmental and public health, a couple of just all really health education integrated with public health courses. And I am a TikTok live host where my niche is all about helping people with their overall health and wellness with a spirit, mind, body approach in hopes that I can align them on their healing journey and hopefully assist them off of the platform navigating that process for them.
I love that. Thank you so much, Miss Sinedra. Miss Sinedra, before we continue, am I saying the name right? You know, I got a little accent. Is it Sinedra? Please correct me, ma'am.
It's Sinedra.
Sinedra, okay.
Yes. Hi, everyone. Hi, my name's Sinedra. I am a registered nurse. I am the owner of Velasance Aesthetics and Wellness. I'm also currently in school for my FMP as well as my doctorate. I have experience in working in a variety of specialties. My main specialty is the operating room, surgical services, cath lab, endoscopy, a little bit of L&D, and I love aesthetics. So that's a little brief synopsis about myself.
Thank you so much. The mogul social worker, go ahead. Before we continue, ma'am, is there any specific name you want me to go by? You did send me your government name, but are we going by your government name here on TikTok or how you want to do?
It's government is fine with me.
Okay, that's fine, ma'am. Okay, go ahead. Your brief introduction.
So my name is Davidra Bazemore Blue. I am known as the mogul social worker. It is really a play on the MSW degree that social workers get. And my expertise really as a social worker, first, I'm the owner of True Blue Behavioral Health, which is a group practice. We have specialized in public health related training, behavioral health treatment, policy writing, child welfare services. I worked in correctional mental health and military. So for me, my career has really been about the kind of intersectionality of all of these systems. And it's in some way kind of manifested its way into me primarily now focusing on employee assistance related work, workplace accommodations, workplace safety from a behavioral health, mental health, but also, physical health standpoint. And so that has kind of garnered me a little bit of feedback on TikTok. That's how we came to know one another. And so it's a pleasure to be here. It's a pleasure to see all of you, because I love to see brown people doing their thing, and y'all are also beautiful.
They are. Yes, they are. So thank you guys for those brief introductions. We're gonna jump right into it. You guys are already lighting up the comments. The posh history professor said she said say her name. Yeah, because there's some people who have their alter egos, but Ms. Devidra said say her name, so we're gonna say her name today, okay? Before we get started, quick housekeeping duties. Thumbs up or praying hands is me acknowledging you guys in the chat. I don't want to interrupt my speakers, so a thumbs up or praying hands is me acknowledging you guys in the chat. Don't think I'm ignoring you, and don't think I'm not appreciative of you guys and all your efforts engaging in our conference, okay? Same thing with them. A thumbs up or praying hands from them is them acknowledging you guys as well in the chat. So briefly rundown. You guys know I do my homework. Can we drop in the chat? Dr. Johnson does his homework. So as you all know, okay, Miss Sinatra, I'm printed it out. So I do my homework. Can we drop a couple? I have new stickers. I do my homework. Dr. Johnson does his perfect. There we go. Thank you so much. Also, I have only bring on subject matter experts, and that's who I have here today. Can we drop the subject matter expert stickers in my chat as well too? Subject matter experts only. That's only who comes on Dr. Johnson. Okay, Dr. Johnson does his homework. Perfect. Miss Mika, I see you. Miss Mika, welcome on in. I'm glad you're here. So I want to jump right into it. I have a variety of topics that we're going to go through for everyone. We're going to be discussing understanding the problem. We're going to be discussing access to care. We're going to be discussing systems and policy, mental health. Always got to discuss mental health. Then we're going to be having a reflection and advice section. Then we're going to go on down to lived experiences and community impact. That's important. And then we're going to round it off with solutions and the future. Everyone in, thank you so much. We are, this is the Minorities in America, a public health issue conference. We're going to jump right into our first topic, okay? Understanding the problems. Ms. Devidra, I think I want to start off with you on this one. What are the most urgent public health challenges currently affecting minority communities in the U.S.? And once Ms. Devidra chimes in, anybody else can chime in after that. I'll repeat the question one more time because I just jumped right into it. I don't know if y'all was ready. But yeah, and Dr. Henry already leaning in, okay? Ms. Devidra, I'll repeat it for you one more time. Right. What are
it's definitely a loaded question when I was looking at the list, but I have to say, if I gotta pick some stuff, right? Maternal and infant health, that's like a flashing red light, right? Particularly for Black women, it's not a biology issue. Like, Black women aren't just dying because we're biologically inferior and aren't able to carry children to term and birth them safely, right? It is a systems issue. It is a care delivery systems related issue that is leading to those deaths. And after that, I would say really chronic disease patterns, but by zip codes.
Mm-hmm.
Okay.
Okay.
Okay, no, so I know what you mean. I know what you mean especially when it comes to school systems and zip codes. But what do you mean by that when you says especially with zip codes? What do you mean?
I mean, where there is lower economic opportunity,
Okay.
where there is lower SESs, you are going to see, unfortunately, higher levels of crime, but you are also going to see in Black and brown communities, you're going to see highways that are next to our communities. You are going to see, these data centers that they're putting up, they're right near our communities. You're going to see higher rates of asthma. You're going to see literal diagnoses tied to these lower socioeconomic areas, these particular zip codes. And again, it is not because they are just inherently chronically ill. It is because of the systems that have created patterns of business and policy that have them in situations where they have exposure to things that other communities and zip codes just don't have exposure to, that wouldn't even be permitted there. So those are the two things that for me, I think maternal health, maternal mortality rate, and just that pattern of chronic disease patterns.
Yes, Mr. Nedra.
I just wanted to piggyback on that. I'm actually doing my doctorate project on the maternal health disparities among Black women, and that was my answer to that question as well. In light of recent events, it's becoming an unfortunate popular reoccurrence within our community. But now, because we have social media and people can record in real time, it's becoming infamous instead of the opposite, right? Like, we don't want to be known for the fact that when we go into the hospital, we may or may not get care. And it's really a near and dear subject for me because, one, I'm waiting on my first grandbaby at any moment now. She's officially due tomorrow. And thank God we haven't had any issues, partly because I've been on it and I've made it very clear. I understand how this process works when I go with her to her appointments. But also, we made sure to research the type of care that my daughter wanted. She wanted to make sure that her physicians honored her birth plan and to have that education. And I mean, I'll have to get into the other things, but maternal care is definitely a very important subject that I'd like to discuss tonight, because I think in our community we have, how can I say it? It's not that we don't have the knowledge, but we also have a fear that's ingrained in us. And some people were just taught to trust what doctors tell them, unfortunately. And sometimes they don't know that they can question or that they can advocate for themselves. And so if there's anyone that's on this live tonight that aren't in the medical field or are expecting, I want you to know that you can advocate for yourself. There's a ton of resources that are available to you that come with your insurance, which we'll talk about later about access of care. But there's so many different things. I can go on a tangent because I've been researching it, but there's so many opportunities afforded to us that we just don't know because of lack of knowledge. And that's one of the things that I'm hoping to work on in my project and as something that I'm truly passionate about. So yeah, sorry. When she said I was like, yes, that's it.
Right. I love that. Dr. Trish, anything you want to add to that?
Yeah, just I mean, everything that they said, but just hitting on specific chronic conditions, really what has been, for decades been the top chronic conditions, right? With some shiftings here and there, but I would say diabetes still remains very high, hypertension, heart disease, and obesity, and now we have Alzheimer's disease that has escalated, and they have all been rooted in structural inequities. Mental health is a big one. There has just been so many mental health challenges that are driven by chronic stress, trauma, discrimination, and just people living on survival mode. They live in survival mode every single day. There's environmental health issues right now that include just very poor quality of air. I live in New York City, one of the poorest quality of air environments in the tri-state area here is the Bronx, New York, but overall, all of New York. Unsafe housing issues, food deserts, and just limited access to preventative and primary care because of systematic barriers.
Right. Thank you so much.
Can I piggyback on her statement really fast? So sorry. Only because you guys are about to, and hopefully you don't, I hope that their union settles. The medical system in New York is very interesting. Of course, not because of the diverse populations, but because of their operating system. They believe in working with less and putting a very large load on their medical staff, specifically their nurses. When you think about like the floors, the medical surgical floors, telemetry, etc., standard practice is that you would have maybe 5 patients to 1 nurse. However, in certain hospitals in New York, they'll have 10 patients to one nurse. And that's very hard for a nurse to care for a patient in an 8-hour or 12-hour shift to totally give true care to them, in addition to a physician rounding, periodically and seeing the patient. But the nurse ideally is the person with that patient throughout the shift. And when you mentioned that, it's like, yeah, there's a lot of systemic things that we as a community, I don't know how we're going to be able to break them down. It's things like this, having these panel discussions. I believe in us bringing it inward, even though this is for the world to see, it's still kind of for us, where we can go underground and plan and, be able to put things in place so that we can get the knowledge out without it becoming something that they can cut us off at the knees with, if that makes sense. I'm trying to choose my words correctly for TikTok, but we have to find a way as a community to get this information out in a way that is digestible, a way that they can understand what we are trying to teach them and inform them on with regards to their rights in healthcare, with regards to ways that they can, not necessarily, I don't want to say treat themselves, but knowing that their diet is important, knowing that, diabetes is now, Alzheimer's is now considered diabetes type 3. That's new, and a lot of people don't know that. And understanding that cutting your sugar intake could help prevent that is very important. In addition to, our grandparents and our parents, I'm a millennial, I don't know, I guess I am millennial Gen Xer. And so now I have a baby boomer that I'm responsible for to a degree with my mom and her age group. They have a lot of beliefs that we're trying to deconstruct, and they're very
Say
set
that word
in their
again.
ways.
Say that word again. You trying to what?
Deconstruct, right? Yeah. And so, they have all of their different thought processes, and it's very hard to get them to understand, hey, we need you to take your medicine, you're not being compliant. I always tell my mother, she's my most non-compliant patient ever. They give her the medicine and it just sits on her counter, and she's like, oh, well, my head hurts now and I'm dizzy. Well, Mom, did you take your medicine? Your pressure's probably up.
Right.
So it's a lot of re-education that has to happen. Sorry, I'm babbling. Okay, I'm done.
Thank you so much. No, that's why you're up here. Subject matter expert. Can I have 2 people drop in the chat subject matter expert before I hop on to my next question? Because you see, these ladies came prepared. These ladies came ready. Okay, subject matter expert. Perfect. I see you. Thank you so much. So, Ms. Davidra, I want to come back to you. How do social determinants of health, which include housing, education, income, and environment, shape health outcomes for minorities overall?
I mean, ultimately, all of those things that you listed in our country have been shaped by centuries of racism. So
everybody lean in. My God, damn you! Sorry, we just.
I mean, everything that you listed, all of those are shaped by the racism that we've experienced in this country, and racism drives health inequities in housing, in wealth, in education, in employment, right? And I think that the data would show that needs within these minority communities are always just generally higher. They're higher in these areas because they're already starting from a disadvantage point. And if you know, you just know whether you're disadvantaged because economically you've not had access, or now your family is economically in a place where you have access, but informationally you're disadvantaged because you didn't have access to the people who knew, right? To be able to share it with you there. So you don't even know what questions to ask, which is oftentimes where our wealth struggle comes from. We don't know how to fix our wealth issue in our community because we've not even had access to the people who have had the wealth to be able to gain the information that we need. So it's, gosh, it's just so much. But the social determinants, it's like, there's so many different categories that I'm thinking about, but I'm thinking about, with housing, I'm thinking about school absences, I'm thinking about child welfare contacts, right? When you have this structural racism that exists, the incident of people coming into contact with certain systems are directly impacting their outcomes. One of the tools that I use for all of my patients that come into my practice is the ACEs questionnaire. The ACEs questionnaire is about average childhood experiences, right? This is a very basic thing to be able to get a feel for the experiences that people had in their early child development. And that might have been your adolescent years, right? But we're just talking about your childhood. And so if you were fearful of someone in your home, if you have someone who was physically abusive, an alcoholic, an addict in your home, if you were had unwanted touches by someone who was 5 years or older than you, right? These are primary experiences that Kaiser, who I am not employed by and do not represent, honestly don't even like them. But Kaiser did a great thing with their research around ACEs, because what they have realized is all of these are indicators, social determinant indicators of negative outcomes, whether they be social determinants with policing, crime related, domestic violence, intimate partner related issues, or if they're medical negative outcomes with hypertension, with diabetes, those sorts of things. So the higher your ACEs score, and I believe it's 5 or 6 or more, the more likely you are to have these negative social determinants. And when you tie these experiences to where these people come from, and we just say we're going to look at certain populations, whether you're Black, whether you're Hispanic, whether you're Native, Indigenous, whether you're Alaskan, right? There are various minority populations throughout our country who have just had very little access. And when they then have these experiences with lack of access to equal care and equal systems, even legal protections, they have poor outcomes.
Yeah.
Right. Thank you so much. Dr. Trish, I want you to, from your acquired professional skills, I want you to piggyback off of her, please.
Oh, I'm going to go into the personal right now.
Okay.
I have 9 of those ACEs.
Okay.
9 of them. And I do not agree with Kaiser Permanente either, but they did do very good work with this particular resource that they've been using. And when I found it, I looked into it, I researched it, first for myself, then for my children. My daughter is biracial. My granddaughters are biracial. We are at a loss when it comes to having access to resources. Personally, in my family, it was just access to information. It was access to being able to discuss certain things in the family that were relevant and was taking place, the elephant in the room, right? Not it not being discussed because those were that was the type of upbringing that we experienced, and not being able to seek for help, right? Seek for these resources. Unfortunately, there is mental health issues in my family. It struck my brother. He's passed on right now. Unfortunately, he was the one that was incarcerated. We came as immigrants to the States in the 1980s. And I'm the youngest of 3, 2 other brothers. My other brother struggled with drugs and alcohol. He may still be struggling till this day. And I'm the one that was just basically all in school, had my own struggles myself, but thank goodness for education, for wanting to know better, learn better, do better. Had a daughter. No, I gotta stop. I have to do the right thing. I have to be a good role model. I don't want her to, follow the things, that were passed down generationally. I went ahead and I did what I had to do. I struggled a whole lot because there's a lot of trauma that had to be, pretty much faced with, a lot of healing that needed to take place. At the same time, in survival mode of working full time, being a single mom, going to school, doing the papers, doing all the things. And so on a personal level, I totally get it. And I agree with everything that was just said. On a professional level, we have the social ecological model, right, that we can take a look at. And it's basically a model or a framework that is used in health education and public health as well, that looks at all of those things that affect the individual. And health educator Lou can probably talk about this as well as she comes in. We're talking about the social ecological framework, health educator Lou. But basically, it's looking at the individual with what is affecting or impacting the individual at their closest quarters in the home, right? That's one layer. Outside that layer comes what's in most proximity, okay? So the environment, their neighborhood, where they live, okay? The next level is where they work, where they go to school, what kind of social networks they have, and so forth, right? How do they exchange communication? What does that social life look like? What does that look like? How does it impact them? How does it affect them? Outside of that, the next would be the governmental, right? And what's going on social, politically within that layer, that hemisphere. And so that's what the social ecological framework is telling us. All of these layers impact the individual. And so that goes with housing stability, education quality, income, employment conditions, neighborhood safety, significantly influence health outcomes. Many immigrant and minority families prioritize survival needs. I can say that because I did. I prioritize survival needs, okay, over preventative health. Health behaviors are shaped by access and opportunity, not lack of motivation.
Dr. Church, thank you so much for sharing that. Thank you so much for being so transparent and sharing your personal experience. That's important, and that's why you're up here once again. Ms. Sinidra, do you have anything you want to quickly add before I allow Health Educator Lou to give a brief introduction?
Sinedra, and yes.
Sinedra, please make sure you continue to correct me because I'm not doing it on purpose. Send Miss Sinedra, please, okay? Anything you want to add to piggyback off of what Dr. Trish and Miss Davidra just said?
So, full disclaimer, I do work for Kaiser, but I get it. I would, I know I'm like per diem. I understand.
They pay well.
They pay well. I'm in California, so they're here everywhere. I'm originally from New Orleans, so to be able to speak to the disparities, I can definitely speak to that. I think environmental would be the subject that I would choose for the social determinants. Growing up, I lived in New Orleans, born and raised, and then my mother moved to what they would consider a suburb, and it's in a city called Laplace, Louisiana. And I don't know if you guys are big on documentaries, but a while back they did a documentary on what they call Cancer Alley. And what that was there was this area, well, it still exists, where DuPont, which is an oil refinery, built their refinery within the neighborhood. And for years, people started getting cancer, people were losing their babies, and they couldn't figure out why, even though it was staring them right in their face. And finally, after years of kind of going back and forth, they were able to determine that, in fact, the oil refinery being that close to the neighborhood was, in fact, killing its residents. And to this day, well, I get a message today, because I still follow the news there, they're wanting to open a new oil refinery in the neighboring parish, which in Louisiana, we have parishes, not counties. And so where my mother lives in Laplace, that's St. John Parish. And the neighboring parish, which they call like the Tri-Cities, because it's St. Charles, St. John, and St. James. And within these three parishes is where the bulk of the oil refineries are. It's like a whole neighborhood of oil refineries. But then they took the ones from, well, they didn't take them. There's a bunch in St. Charles Parish where it's a whole like mini city, if you will, of oil refineries. And then they moved one of the companies to Laplace, and they put one in the middle of LaPlace and Reserve. Well, Reserve has its own as well. And then you go to St. James, which is like 5 miles up the road, and now you're in the next city, quote unquote. And now they're talking about building a brand new one. Well, here's the issue with that. We've already established through the data that putting an oil refinery next to a community will cause health problems. Why does our government think that that's okay? Why? The land is cheap and they don't care about who lives there. So the community, of course, is trying to come together, i.e. why I received this email, because they're trying to get their petitions going to hopefully be able to stop them. But it just, piggybacks off of Dr. Trish. I'm sorry, what's your last name? I can't see
Dr.
it on
Trish
here.
Lopez.
Dr.
Dr.
Trish
Lopez. Okay, do you prefer
You
Dr.
can call me
Trish or
Dr. Trish.
Lopez?
That's fine.
Dr. Trish, yeah.
Okay, all right. But to piggyback off of Dr. Trish, when you are in an environment, you're taught to survive, especially in minority communities. We only had one high school to choose from. They still to this day only have one high school. You have East St. John, and on the West Bank, you have West St. John. So there's nothing else unless you go to a private school if your parents can afford to send you there. So if you take away the resources, you're now hindering that community. If you take away the food, the kids can't eat lunch, which was another issue that happened. New Orleans public schools are dealing with a really big crisis right now because they want to shut down an additional 10 schools. Well, after Hurricane Katrina, they switched to a chartered system where they took the schools and tried to combine them and make them chartered schools. Well, now they've decided that charter schools don't work, and they are now, after this school year, are closing 3 to 4 more schools. So now they have to bus all of these children from different communities. And while it shouldn't be the focus of who likes one another, let's be real. If you live in an area and you've been known for your area and that area is known to not like the next area, you're setting yourself up for failure for that who is going to claim what territory foolishness that will occur. And it is what it is. I'm not saying it's right or wrong. It's just something that as a community, they're going to have to deal with. And again, my city is known for shooting first and asking questions later. It's definitely not something to brag about, but it's our unfortunate reality. And so that plays a major role when you also have closed down hospitals, when you shorten staff, and now you can't even go in because look at the insurance. As of January 1st, people aren't going to be insured because they're not voting. So there's so many factors that affect our communities as minorities more than the others because of the structural racism that has already been put in place to already have us 10 steps behind. So
Thank you for sharing that perspective. Health educator Lou, welcome. Listen, I know life happens. Don't worry about it. No stress. I told everybody you'll join in when you join in. I know life happens. So before we get started, can you give us just a brief introduction of who you are, what you do, introduce yourself to the people then? Obviously this is social media, so whatever name you don't want to share on here, you can just give us context clues, but take it away.
Hi everyone. So sorry I'm late, but happy to be here. So my name is Lou Anna, but everyone is welcome to call me Lou. I go by Health Educator Lou on my social media pages. Right now, I currently am the founder of Community Wellness Consulting, where I partner with schools, community organizations, and families to basically support holistic and community center wellness. I work for a health department in Chicago, and I do a lot of positive youth development in suicide prevention in the community behavioral health space. And I've been working in public health for about 6 to 7 years now. And a lot of my work, because you all are talking about social determinants of health, and that's my favorite. So a lot of my work actually does focus on social determinants of health, and that's both professional and personal for me. I'm from Chicago, and I did grow up experiencing poverty, so I've seen firsthand how structural racism, disinvestment, and limited access to resources show up in people's mental, emotional, and then also their physical health. So because of that, my approach to business and also with what I do at work is very healing centered and trauma informed. So I'm definitely happy to be here and a part of the discussion with you ladies and also with you, Dr. Johnson.
Thank you so much. Can we drop subject matter in the expert for her before we get started? Before we continue, can we drop the sticker subject matter expert in the chat? Because you know I only invite subject matter experts. Did you hear the resume? Perfect. Thank you so much, Dr. Henry. The mogul social worker, I want to get back to you to answer this question, and then I want Miss Lou to follow back up with you, okay? How does structural racism show up in public health data and outcomes? Everybody lean in. Lean in because this is important, okay? And can we drop a lean in the chat? I'll repeat the question one more time for the mogul social worker. How does structural racism show up in public health data and outcomes? Take it away.
I gotta tell you, as you said it, I'm just like, I don't even really know where to start because I feel like that is just a landmine.
Right.
You know, this is a twofold discussion. And I think I'm gonna take the foundational part of this answer because I see the people in the chat and I see we got a lot of doctors in the chat, but I know that we have some other people who may not be doctors, but still educated in their own way. Right. And so I want to speak to us as people and beyond just like our academic stature, right?
Right.
When people hear the word data, a lot of times they turn off. Okay. I'm a social worker. Only thing I know how to count is money. All right. Like I do the stats where I need to do the stats, but you know, like I'm not a statistician. That's not my ministry. Okay. And most people would generally tell you that's just not their ministry. And so what I know as an individual prior to even coming into a space where I had to take a statistics class, right? Before we even got there, when people would start talking about numbers and stats, it would just turn me off because that wasn't an area in which I was strong. But you know, with time, what I've learned and what I'm sure a lot of people have learned is instead of turning off and tuning out when those numbers come up, we really have to start listening, right? We have to start listening not to the sensationality of the volume in the numbers, right? Because sometimes people say, well, 80% of this or 50% of that or 40% of this population all has some linkage to substance abuse, you know, or some addiction issue. Speaking specifically to Baltimore City right now, I don't know why that stat is in my mind, but we hear these stats and you rattle them off, and then it's like, okay, so what does that mean? Like, where does it go to? And we have to become critical with respect to, well, who wrote this data, right? Who put these stats together? It matters. What is their motivation? What is this company's motivation and specialty? Who do they get funded by, right? And it requires a lot of homework that unfortunately, as we've seen by this last election, most people don't want to do. We can sit here and rattle off the indicators and why it's not valid or why it's racist or why they're moving how they're moving. But when the stat comes up on the TV screen and people are just looking at it, they take it for what it is. Either they don't trust it and they don't believe it, period, because they don't believe nobody's stats. Right. I love my older people because I said all them people lying. Like they don't believe anything. Or they just believe whatever got thrown up there. And because that's their regular news channel that they look at, and they believe they take them at their word and they don't know where it came from. They don't know why it matters. And there is this exhaustion that people have right now with having to look up absolutely everything because we want to be responsible with where we shop and who we do business with. And you're trying to get to the nitty gritty on where is all this money going? Where is it coming from? And for what function and purpose? Because that's where we get to when we start talking about like the data and the impact to these outcomes, right? What is the purpose in manipulating said data? So I'm going to take the position on this of I understand that when people hear about the numbers, they ain't usually in love with it and they don't want to listen. But I will also say, please, let's start really taking the time to figure out where this data is coming from and who's behind it, so that we can kind of start to assess for ourselves how valid it is. And just asking more questions around it. Well, why is that? Because I swear, if you ask why 5 times, you can get down to a truth that wasn't revealed the first time. Like, just start asking questions about it. Become more curious about the data, so that you can then decide if it really represents the truth of your experience and your family and friends' experience, your community's experience of what they're saying.
Right. I love that. Thank you so much for sharing that. Miss Lou, what you got to add to that, ma'am?
So for me, I do a lot of, actually I feel like too much, because that's probably what's causing a lot of my stress right now, but I do a lot of reporting with the health department that I work for now in Chicago. And yeah, we have to do a lot of reports and we go into a lot of data. For me, that's always a touchy subject, because I think the Black and brown community, we have a lot of structural racism and historical trauma. So for me, what I like to do when it comes to data is actually go out in the community and work with my epidemiology unit. And everybody, I'm pretty sure everybody knows what epidemiology means.
And if they don't, what is it? If they don't, what is it? Let's assume they don't. Break it down for us, health educator Lou.
Okay, so epidemiology is basically the possible control of diseases and other factors relating to health. So you can be an epidemiologist, you can become a doctor, but it's basically it's also in the same field as in public health. So I work with our epidemiology unit to get a lot of data, and my method is actually going into the community and doing focus groups and asking the questions that need to be asked, because qualitative data and quantitative data, it's not always the same thing, and it doesn't always produce the same results, if that makes sense. So it's important for me to actually go out there and receive what I need to receive from the community that I am trying to get the data from. So with that being said, I'm trying to put it in plain language. But with that being said, it's, for me being a Black woman, especially working in a position that I'm working, it's important for me to represent my community and go out there and receive, since we did experience a lot of historical data, it's important for us to actually go out there and get the answers, because sometimes I have to fight all the time at work to receive. For example, with suicide, we're noticing a higher increase in youth, preferably a lot of young females are experiencing a lot of suicide ideation. So I have to advocate, because the raw data says that no, this is a white male issue, but we're seeing an incline in Black and brown communities. So that's kind of my stance. I have to actually fight for the communities that.
Thank you so much for sharing that. For everybody just joining on in, welcome to Minorities in America, a public health issue conference. I have 4 subject matter experts on here who are dropping gems and sharing their acquired skills and professional knowledge. We're going to wrap up the section of understanding the problems, okay, because we got so many other topics that we're going to have to touch on. But Dr. Trish, I want you to share your expertise on this question. Are there any health issues affecting minorities that are often overlooked or underreported? Can you just briefly touch on that topic so we can get into our other important topic of access of care? I'll repeat the question for you one more time. Are there any health issues affecting minorities that are often overlooked or underreported?
I would say definitely mental health. I would say psychosomatic conditions. I would say, being a health educator, and Lou can appreciate this and for sure understand, we go out into the communities and we try to we try to do the work to prevent diseases from happening.
Right.
And so much of that is not being reported.
Right.
The only good amount of data that I would say that I've seen in journals, and I was also a board committee member for a study taking place out of Mount Sinai Hospital Health System here in New York, was diabetes for adults and also for teenagers. But when it comes to prevention, I have not seen any of those numbers, and God knows, I don't know how many years. I've never seen it. I don't know. I've just never seen it. But I know what I'm looking for when I go out there and I work with individuals, when I hear what they're saying as far as their symptoms, what they're complaining of, what the potentials can be. And that's my passion, because I sense it, I hear it, I see it, and I'm always trying to prevent things from happening. So there is a whole bunch of different types of health conditions that could be prevented. But if we were able to stop saying to ourselves, there's nothing going on, oh, it must just be this, or it might just be that, and not pay attention to those types of little hints here and there that your body's always sending you, we can actually have much more prevention take place. But that's not happening. So I would say that those would be the for me, what I've seen and what I've experienced as a health educator. Those would be the ones that are most significant for me. The psychosomatic, for sure, because I focus a lot on the emotional health with the work that I do with potential clients, with what I'm trying to do here on TikTok. And I would say, obviously, that parallels, right, our mental and our emotional health. But the physical health, right, there's so many things that are happening in the body, in the physical body, before it gets to be a blood lab gone wrong, a blood sugar level gone wrong. And so many of those are not being reported because it's not a focus. It's just not a focus. Systematically, it's not a focus. And so, that would be my best answer.
Thank you so much for sharing that. I want to head over into the access of care, and I want to tap into the Mogul social workers' professional experience, and then I want to tap on the rest of you guys for what your take is on it. Okay, so the Mogul social worker, Mr. Vidro, what barriers do minority populations face when trying to access healthcare services? I know you, as a social worker, you work with various different healthcare services. So once again, what barriers do minority populations face when trying to access these healthcare services overall?
The primary barriers are, when I think about medical health, and I'm specifically thinking like somatic, like physical health, that's going to be your insurance. The insurance barrier is massive, right? That's the one side of the house. And then on the behavioral health access, it is just structurally restricted with behavioral health access. Like mental health providers, when you talk about minority populations who, let's just start with people who are, getting their healthcare via Medicaid. Mental health providers who are accepting Medicaid have low reimbursement plans. Okay, let's start there. The reimbursements are very low, unless of course there are some random locations throughout the states where they have a pretty decent reimbursement. However, if that reimbursement is on the higher end, it's because these businesses have had to go through state licensing procedures. They've had to pay for thousands of dollars for accreditation. Like there's a whole other subset of criteria that has to be met in order for the business to then be able to get what are reasonable reimbursement rates. Still lower than what an individual would probably be charging private pay. And then from a different minority population subset, but I'm going to look at our military population and specifically our minority military population. These individuals have TRICARE insurance. If you're not familiar with TRICARE reimburses less than Medicaid. Tap into it. Okay? No one wants to accept TRICARE other than for the sole purpose of providing a service for veterans and active duty members because they care. It is not because they're being compensated what they should be being compensated. And so getting and finding competent, culturally competent clinicians, bilingual providers, because as people are finding out, maybe I'm sure we know, but many don't, that there are immigrants in our military whose first language is not English and who would like to receive their health care from someone who speaks their native tongue, right? That's not unreasonable to ask. And so getting access to language services is like between the insurance piece, and I'm holding off on the insurance piece because that's just, it makes me want to.
I'm a military wife, girl. You preaching right now? Because
It's,
listen,
you know, the
I'd
wait
rather pay out of
list,
pocket sometimes. It's ridiculous.
the wait list to be able to get in to see a provider, the way that service is happening for this small niche population of minorities in our country who should not be struggling to get the care that they're getting, right? But the way that it is happening is providers are carving out, oh, I got 3 spots for TRICARE. I got 5 spots for TRICARE in their entire caseload. And people who get those spots tend to try to stay with their therapists as long as they can. They don't open up often. And so just the access for that very special population is something that is shameful, honestly. And it leads to negative outcomes within the military sphere in terms of their behavioral health. And I think that they're trying to do a lot internally to mitigate the stigma around behavioral health. I know I do a lot of work with the Coast Guard. Don't hate me because I know that's DHS and no one likes them right now. But I do a lot of work with the Coast Guard, and we have been putting out a lot of information around your security clearance and your behavioral health, and actually releasing the data around how many members are relieved of duty, separated from the Coast Guard because of their psychological diagnosis, their psychiatric diagnosis. And the reality of it is, in the last 3 years, there have been 3 people removed from the Coast Guard because of some psychiatric diagnosis, typically tied to a diagnosis with psychotic features of some sort, right? So we're trying to enhance their awareness around people in the Coast Guard and in other military branches are taking anxiety medications, antidepressants. They are taking, mood stabilizers. They're doing a variety of things. And role and position, whatever their MOS is, their job, it matters, right? Because pilots have limitations. But yeah. The access to behavioral health is specific to that, these 2 areas, your Medicaid clientele as well as your military personnel. Those are just some of the things that they're struggling with. On the insurance side, anybody can take it because I know it's good.
Yeah, we're gonna swing back on the insurance side. But Dr. Trish, how do you think language barriers and cultural differences impact health care quality overall?
Miscommunication. Miscommunication between providers and patients. A sense of superiority that for some reason patients, feel that they can't ask questions, ask for second, third, fourth, fifth, sixth opinions. That's something that happens. And I've been in actual patient rooms where this is actually taking place because I worked for an outpatient clinic for 4 years as the sole health education specialist there. And I work with all the doctors. And I could just see, I would just look at this dynamic, and I would see the patient afterwards because they were referred to see me for whatever type of condition or situation going on with their health. And I would empower them. I would talk to them. I'd be like, when next time you go and see Dr. Smith, please, let's ask some questions. This is what she said to you. You can ask questions. Do not feel that there is this huge separation between a medical doctor and yourself. You have every right. You are their patient. If it wasn't for you, they would not be in business.
Right.
You can definitely advocate for yourself, ask questions, and if you do not agree with the doctor, that's okay. You can go and see another doctor and get second, third, fourth, fifth opinions. And so I think it's just, the miscommunication between providers and patients, and how, when I say miscommunication, I would say like the health terminology, right? Because patients feel inferior to that type of terminology. It's the tone, I would say, that some doctors have, sometimes the mannerism, sometimes the urgency of getting through a conversation that should take at least 15-20 minutes in 3 minutes, and the patient sense that. I would say also cultural norms of respect may prevent, right, patients from asking questions. So it's cultural, right? We do not question the doctor. We respect them, right? You can respect them and still ask questions,
Exactly.
right? Medical instructions are not culturally tailored, okay? And they're not fully understood by the patients. So there's miscommunication and perception issues with that whole dynamic.
I love that. Thank you so much for sharing that, Dr. Church. Miss Lou, I didn't forget about you. I know you're down there. So we're gonna go back to the insurance question that Miss Devidra just saved for somebody else. But Miss Lou, from your professional experience, in what ways do insurance coverage gaps disproportionately affect minority communities? Let's talk about that. Everybody lean in. Can we drop a lean in the chat, please? Because we're talking about health insurance coverage. Everybody lean in the chat. Miss Lou, take it away. What you think, Miss Lou?
Well, I think, she did a really great job answering that question. So I think she covered just about everything. I'm also a veteran myself. So I've definitely seen firsthand. The insurance is definitely trash, especially when you are out of the military, for sure, and you retire. Might as well get you some more insurance. But anyways, I've been a community healthcare worker before. So as Dr. Trish mentioned, she went into the hospitals and went with the patients or went with the clients and actually saw firsthand what happened. So I also saw that as well. So I saw delayed care. If a certain, especially in rural environments too, because I've been not only in Chicago, but also places outside of Chicago where it's very, very rural. And if they have Medicaid and there's doctors around the area that doesn't really accept their type of Medicaid, they will have to travel super, super far, or basically change their insurance and get it in the network. But basically, people are less likely to seek preventative services or treatment early, which can lead to a lot of illness later on in life. So I've seen that as well. Limited access to providers. As we've talked about, even when care is available, some clinics or specialists may not accept underinsured patients, creating that geographic access barrier, financial strain. So I've seen a lot of, even within my family too, there's certain insurance that, not even just with Medicaid though, it can be like with regular insurance. Like, let's say you don't qualify for Medicaid, for example, and you pay for a regular insurance. I'm trying to give an example. Maybe like a company that don't really have really good, like they said they pay for your insurance, but it's not really good insurance. I don't know how to explain it, but I think you all get it. But you go to the doctor and let's say, oh, I just want to make sure my thyroid gets checked or whatever, right? But you go in for a wellness exam. Next thing you know, you have a medical bill, $400, just because you went in and got a preventative screening, but they charged your insurance. It's just, y'all, it's just a lot. So there's a lot of disparities in mental health services, disparities in. Oh, Dr. Johnson, was that like my cue to stop
Oh
talking?
no, no, no. Oh, I'm so you
I was
wasn't
like,
here.
am
A
I talking
thumbs
too
up.
much?
No, a thumbs up or a praying hands is me just acknowledging them in the chat. I'm sorry. No, you good. You good.
Perfect. But yeah, so there is a lot of insurance gaps that intersect with systemic issues like poverty, housing instability that I saw being a community healthcare worker, and then transportation challenges, people not being able to get to their. I've also been a caseworker too, so I've seen that happen a lot for Molina Healthcare. But yeah, transportation challenges, making it even harder for marginalized communities to access care. But
I love that. Thanks for sharing that perspective. You guys, we're gonna wrap up access to care with this last question, okay? Mr. Vidra, how does immigration status influence access to public health resources? And Dr. Trish, I would like for you to piggyback after Mr. Vidra.
Today, in the America we live in today, I think that it creates, right now, immigrants have a fear of data sharing. They're terrified about immigration enforcement. All of these things, they're already in situations where they're receiving care from very overburdened systems, because that is just the nature of public health when you are in these minority communities. They're underinsured. They're oftentimes receiving care from, and not that people are lesser qualified in any way. It's just they're understaffed and overburdened. So when immigrants are faced with having to go into places today that are, it's already a stressful place to be. Now I have to worry about whether or not I'm in a community where ICE is patrolling, whether or not this is a clinic that is frequented by immigrants because, of the language barriers and access to care. This is the one clinic in the area where I know they have people that, I can speak to and talk to. They have translators readily accessible, because in some communities, maybe there's only the one clinic that you're uninsured and underinsured are really going to, right? And then in addition to that, you're in states where, God forbid, you be pregnant and it's an unwanted pregnancy, and the information that you might have to share in that appointment, right? So the data sharing, and then the criminality behind that, and the tracking. There's so much surveillance that is happening even within our healthcare in ways now that never existed before, that it makes it extremely unsafe for immigrants to be able to access care and to engage in services.
I love that. Dr. Trish, anything you want to add to that before we wrap up the access to care?
Can you repeat the question?
Yes, ma'am. I know it's heavy. How does immigration status influence access to public health resources?
When this all started with the situation with our immigration, I said that was me when I was 6. I came here as an immigrant. One of the best things that my dad did was to go and get our papers, right? To get our citizenship, and go through the classes and go through the process. And I remember, I think I was like 17 years old, and we all did it together as a family. And that's one of the best things, honestly, that he did for us. Right. And for me to see what was going on, not in the regular news, find those pages to find out what is going on and seeing what is happening to Latinos, Latinas, their children, their families, has been extremely difficult to see happen, because that was me. That was my mom. That was my brothers. That was my dad. That was my uncles. That was my cousins, my whole family. We all migrated here. And to not have any type of emotion connected to that is completely inhumane, for me. So very difficult, very difficult. But the fear of deportation or public charge policies discourages service use. As already stated, the avoidance of care, even when individuals are legally eligible, they're legally eligible for these resources. And then the children that are often serve as like interpreters, right? And affecting family dynamics. Children going to court cases with no representation by themselves. I mean, I never thought I would live to see something like that happening. And it's happening every day and so very often. And I asked my fiance, should I start driving and walking around with my passport on me?
Okay. Okay.
For sure.
Right.
You know? And it's horrible. It's horrible. You know, I can't even imagine their lives. I it's very difficult for me.
Thank you. Thank you for sharing that, Dr. Trish, and thank you for
Really
being so
quickly, I'm
vulnerable.
sorry.
Yes,
I'm
go
sorry.
ahead.
I want to add to that because what Dr. Trish is saying, I think what is screaming out at me is the impact of all of this fear, right?
Right.
People didn't go to the doctor during COVID, but the impact of this fear is avoidable emergencies. Like we're at emergency care only because that's when the care is taking place, when people are so ill that they have no other choice, right? These untreated chronic illnesses that are turning into other things because they're just going untreated and they're getting worse. These late stage diagnoses of conditions that maybe didn't have to be terminal, but here we are.
Here we are.
Because there's so much fear.
Right. Thank you for sharing that, y'all. As you guys know, access to care was going to get vulnerable. Access to care was going to get deep, but we're going to slide out of access to care. Okay. Now, Miss Sinedra. I said it right? Miss Sinedra. Okay. With your clinical experience, how do policies at the local, state, and federal level impact minority health outcomes overall?
Well, it's always going to go back to the money, right? And how much we have or we don't have. That's a loaded question. I'm trying to think
break it down.
I'm like thinking of it from the very beginning. Think of a single parent household, right? Where you're having to decide as a single parent whether or not you're going to eat versus your children. Then take it the step further to the school side of things as a instructor and not having the resources because the school district didn't supply it to you. How are you going to get these children equipped to be able to pass their next tests when they don't even have the textbooks, right? There's just so many facets to that. Am I doing the one with the child welfare, criminal justice? That was the question. I want to make sure I'm answering.
No, you
Or
don't.
no, local, state, and federal.
Yes,
Okay,
ma'am.
still
Yes,
the
ma'am.
same.
Yeah.
It's still the same. It still goes back to what they're putting into our communities and how we're able to make $1 out of 15 cents at the end of the day. And it's becoming increasingly harder to make $1 out of 15 cents when inflation has now made the 15 cents $3. Right? And so with regards to healthcare, what I'm seeing is patients, okay, so I work in surgery. And our bread and butter, most hospitals, their bread and butter is surgery. And where they make the bulk of their money is at the end of the year because everyone's met their deductibles. So everyone's trying to get booked so that they can have whatever surgeries they need to have before the end of the year. Well, in light of recent events, we haven't been scheduling a lot of surgeries. I work per diem at a surgery center who typically they're booked up. Like people are always upset because they can't get their surgeries, on their allotted time that they're scheduling themselves off. Our books are wide open. Is it because people are getting healthier? I would respectfully disagree. Or is it because people can't afford to be off work?
Bingo.
Probably. Or they can't still afford to pay whatever is left on their deductible because everything's been short this past year. And so when the states are saying we're going to cut funding to the social services that would help. You know, most people don't know hospitals have a charity fund. So if you go into a hospital and you can't theoretically afford it, you can request that. Now, that's not to say they're going to pay it in full, but something is better than nothing in those regards. And I've heard through the grapevine that a few facilities haven't been advocating in a way that they should. So if there's anyone on this live that is not already in the medical field and you guys are listening in as patients, I need you to know that you can ask for social services. You can ask for a case manager. You can ask if there's any charities that can assist you in paying these bills. Don't let them just tell you, oh, you don't qualify, or not necessarily that you don't qualify or that we don't have anything for you. All hospitals are required to have these services. And so a lot of people just don't know that. And then they get these bills in the mail that they can't afford. And it just becomes a downward spiral effect of the hamster wheel. Like, now I got to get another job. I'm trying to pay this. Now that's taking me away from my family. Now my children are getting neglected. Now the children are acting out in school because mom and or dad or mom or and or dad or whatever is not there. It just becomes this cycle that keeps repeating itself in our community, from part lack of knowledge, but big part lack of resources. And that's kind of my take on that with regards to how the impact goes. Federally, they're cutting funding at every chance they can get. You know, no matter what your preference is, I will say this part before I give that. This is my disclaimer. I don't care what people believe. I don't care who you like, none of that. I don't agree with what just happened here in California. So Sutter is another hospital system that I work for. And I just saw on one of my medical online news feeds, that they are going to stop doing gender reaffirming care effective immediately. So that's a problem, not necessarily in our community, but as a whole, because people are in the middle, have already either been approved or were in the process of being approved. We're on certain medications that was prepping them for this. And now you're saying effective immediately, we're going to stop. That's going to create a whole other ball of confusion. It's going to increase the mental health in the young people that parents decided it was okay for them, the older people who felt like that was their last resort. There's so many factors that come into place when we have our government telling us yes and no to what we can and cannot do with our bodies, in addition to taking the resources that we already had available to us. Don't even get me started on women, because I told my husband we're not moving from California until the other states get it together, because at least we got a little bit of sense when it comes to women's autonomy here in California. But now I'm still seeing, slowly but surely, there's certain things. I mentioned earlier, my daughter's pregnant. There were a lot of questions that she was asked in her intake appointment that I don't remember. Now, my youngest is 24 years old, so I've been out the game with the baby making for a while now. But I was like, dang, they're very, invasive in these questions. I mean, I can appreciate it, but at the same time, I found it to be rather strange that they wanted to know so many invasive things with regards to her partner, their plans. Do you want to have more children? Can we get the first one? It was just kind of weird. This extra line of questionings is what I'm getting at. And I asked them off to the side, nurse to nurse, is this a new set of questions? And they were like, yeah, they want us to ask all this stupid stuff. And it makes it hard for the medical professional, because we don't want to ask y'all that. We really don't.
We don't need
But
to
we
know.
also have a job to do.
Right.
And it puts us in this catch-22. So, yeah, the policies are crap, long story short.
Ms. Sinedra, thank you for sharing that and that your professional experience. Ms. Lou, What systemic changes would most improve public health for marginalized communities? Take us away. I know you got the experience within marginalized communities. So once again, what systemic changes would most improve public health for marginalized communities?
So when we talk about marginalized communities, it definitely requires a lot of systemic changes, and not just individual interventions, right? We need some systemic changes. For one, expanding access to affordable, comprehensive health care. Definitely closing. Can everybody hear me still?
Yes.
You're back.
Okay, sorry. One of my alarms went off. But closing insurance gap, increasing Medicaid access. This year, I've been crying. I don't even know how many times I've cried this year, y'all. But all the things that's just been happening, it's just sad all around. And ensuring culturally responsive care. We already didn't trust the medical system. People of color, when I say we, sorry, but people of color did not trust Black and brown. We did not trust the medical system beforehand. So now with the COVID, and then now all of the things that's happening this year, it's even more. So I think that we should invest in social determinants of health, quality education in our communities, ensuring that our babies are getting the right education. It shouldn't matter what zip code that you're in. It shouldn't matter if you live in a great neighborhood or whatever you want to call the neighborhoods in poverty. It shouldn't matter where you come from. You should receive good quality education. There should be access to employment, which decreases. I'm probably getting into all types of stuff, but that decreases crime. We talked about transportation, but that directly impacts your physical and also your mental health. And then really addressing structural racism. So all of the policies that reduce inequities in healthcare, we already know how deep rooted that can definitely get. And making sure that people are understanding. Well, also, as one, I forgot who mentioned this, so my apologies, but one of you ladies mentioned that when we're in the doctors, we definitely someone should be in the room. Like, we have case managers, there's social workers, there's community health workers. We need to know what's going on, because sometimes we see a lot of patients go into the doctor's offices and the doctors are just giving them like a quick, saying all types of words that I wouldn't even know. With a master's degree, I wouldn't even know. So they come out not even really knowing like what doses they're supposed to be taking, not knowing how to read their medication. So there is just a lot of things that we need in the community. Education, we need more investment and not defunding. We need more funding in the communities. It seems like all of the funding has just been taken away. So that's something that we've been working with the health department. With the health department that I work in too. And really increasing representation and, like I said, cultural competency in healthcare. So
I love that.
it's a lot.
It is a lot, and that's why we're all here. Once again, that's why we are all here. Okay.
Can I piggyback on that just really quickly? Another thing that I would love to share with patients, and as well as anyone who sees a doctor, if you go to your doctor and you don't agree with the diagnosis or the treatment plan, make sure it's documented in your chart. If they tell you no, they're not going to do something you asked them to do, be very adamant and advocate for yourself to make sure that it is put in your chart. That is one way to protect you. It's one way to have accountability for the nurse and or physician. Make sure that you're asking to have things documented in your chart, because now with the whole My Chart app access, you're able to see in real time everything that is in your chart. So if there's ever, God forbid, in a situation, that's what the attorneys, I'm also a legal nurse consultant. That's one of the things we look for. Did you ask about this? Did you refuse it? Did you ask for a second opinion? X, Y, Z. And when we don't see that, even though you will tell us, no, I told them, it doesn't go in your favor for those reasons. So when you said that, it just made me think of it.
Thank you for sharing that subject matter expert. Okay, yeah, they said, okay, Miss Legal Nurse Consultant. Exactly, that's why she's up here. Okay, that's why all of them are up here. We're gonna go over into our social worker subject matter expert. Okay, where do social workers feel the most constrained by policy or funding limitations? Yeah, let's take it there. Where do social workers feel the most constrained by policy or funding limitations?
I'm going to be honest with you and say, in my professional experience, I was listening to First Class talk about, being the nurse and asking the nurse, like, is this something y'all, is this new or, because some questions that they ask can be cultural of that particular practice. They want the patient to feel that they're invested in them and their future. And so some questions are around that. Social workers are professionals who I feel like are the people in the workplace that's going to tell their job no. The social worker at your company, they're the person that's going to look at the CEO in them and tell them, absolutely not. Ethically, I'm not able to do that. So what else you got?
Right.
I'm not doing that. It's clinically inappropriate, right? And so the constraints that your social worker is often seeing in the workplace really comes down to the budgetary and the resources, whether it's the budget of the organization they're working for or the just general resources that are in the community. That's where their primary constraints are coming from, because this year and in recent years, particularly around the immigration piece, and managing healthcare needs for that population of minorities, trying to find access to all of the resources that they need. And I think that we have to when we're looking at healthcare, we really have to look at the intersection of all these different systems of, we have to treat housing, we have to treat income, so employment, we have to treat, public safety. All these things are public health infrastructure. So if they are out of whack, if you're underpaid, right? Because you work for Walmart and Walmart is paying you bare minimum and they're getting a credit for paying you bare minimum, but you also need, food stamps. I'm saying food stamps. That's so old school. But you need food stamps. And, and essentially the taxpayers are paying Walmart to employ you so that you can give our government tax dollars back to Walmart, right? Like all these things. And then you can't take time off of work to go to your medical appointment or to go to see the CPS worker for your child that you're trying to maintain, right? Care and custody of to some degree. Like there's so many caveats to what impacts our public health infrastructure. And your social worker is burned out with everybody acting like these systems are actual silos. And that at no point in time do they ever need to come together and see how they overlap. We live in a society where our children have to be at school after our workday starts and get out of school before our workday ends. And our policies have determined that that's okay. Don't nobody need to be there to pick these kids up. No, what you need to do is take that little bit of extra money you have, which is none, and pay for before and after care, okay? Or leave your child with that new boyfriend that you have, where we see these outcomes in child welfare where your baby or your toddler or your child has been sexually abused, physically abused, assaulted, or murdered, right? So,
my God,
the constraint is the willful ignorance and negligence of just acting like, well, education is over here. Healthcare is over here. Housing is up over there. And, labor, that ain't got nothing to do with healthcare. Meanwhile, you need your union, because if you don't have your union, you work for businesses that will enslave you, not give you a day off, never give you a raise, and then look at you crazy when you say you've been diagnosed with cancer and need treatment and you need to go to your treatment. And they like, well, can you come back to work after?
Hello.
What time is your chemo appointment? Can you finish your workday out? These are the things. They don't want to give you a reasonable accommodation. These are the things that people are dealing with. So yeah. That's what we're struggling with. We're struggling with just profits being more important than everything else we say we care about. The resources and the willingness to work together to create policies that are equitable, because God forbid you say equity today. Like, yeah, that's the struggle. That's the constraint.
Right. Thank you. You nailed it on that one. Everybody so far, we've gone through understanding the problems. We've gone through access to care. We've gone through systems and policy. Now we're going to head into mental health. Okay. Dr. Trish, how do stigma and cultural norms affect mental health care access in minority populations?
Can't talk about it.
Oh,
Right?
right.
Can't talk about it. That's a stigma. You can't talk about generational trauma that gets passed down.
Right.
You're seen as different, um, set apart, cited off.
Mhm.
If you mention that there's generational trauma in your family, well, guess what? Everybody has it.
Right.
We need to start talking about it.
Right.
Get rid of the stigma behind it. Okay? Mental health is often minimized or spiritualized in Latino cultures, and their seeking help may be viewed as weakness or failure.
Right.
And there's pressure to remain strong and resilient. And so we need to come together as communities and really embrace each other and be okay with us being vulnerable with each other.
Right.
We have to talk about these things. We have to be okay with saying, hey, this happens in my family and I want to change it. And how do I do that? Who do I go for help? Who can I talk to? But we're dying in silence. And that's just something that as far as my family is concerned, my home is concerned, my girls are concerned, that's just not going to be the case. And so you got to do the hard work, right? You have to do the hard work. You have to go through that healing process and you have to change things around. So this generationally does not continue to live on into my daughter's life, into my daughter's life, and so forth. So we just have to really talk about it and get rid of that stigma.
Right. Thank you for sharing that. Miss Lou, what would you say are mental health challenges disproportionately affecting minority communities?
So, and this question was different from Dr. Trisha's question, right?
Yeah.
Oh my goodness. Sorry, y'all. Can y'all hear me now?
Yes.
Okay. And this question was, can you repeat that?
Sure. What mental health challenges disproportionately affect minority communities overall, from your experience?
So as Dr. Trish mentioned, for sure the cultural and societal beliefs often frame mental health struggles from what I saw, and also from my personal experiences. Like my dad, he needs therapy, but he don't believe in therapy at all. My granddad, he don't believe in therapy. His way is going to church and just praying it away. And that's causing my little sister to believe that as well. So me working in the mental health, behavioral health field, I do not agree with that. So it's hard to accept that that's their beliefs, and that's what they think that is okay. But that's what is learned, and that's something that's passed down. So I'll just continue to pray about that. But it's basically seen as like a personal weakness or a failure, and it's not. So the stigma is very, it's very, very deep rooted. The fear of discrimination. So people worry about being judged, even losing their jobs. Like I know in the military, I think someone, I'm so sorry, I'm forgetting, but someone even mentioned in the military, they had a mental health struggle, and because I know in the past, like some of my, I call them battle buddies, they've basically got kicked out of the military because of their mental health struggles. And they got out from a medical discharge. So losing jobs, facing bias in the healthcare, because I even see that now. People who have mental health challenges, there's just a lot of discrimination with that. Lack of access or even understanding. So when services are limited or not culturally responsible, individuals, they may feel that they just don't have support, or they don't know where to go to ask for help. The historical, as I mentioned before, trauma and the mistrust that the Black and Brown already community that we already face. We definitely hesitate because it has been unethical research, and sometimes we just don't want people in our business. Like that's just. Sometimes people are just like, I would rather just not. I could just talk to my friend or whatever the case is, and it's just what's being pushed out there. They don't understand that you can actually you can find a therapist or you can get that seek that mental health support. But there definitely have been times where I've seen patients, they were ignored or mistreated from their mental health challenges as well from the doctors. So yeah, that's something those are things that I've experienced in my past working.
Thank you for sharing that. Mr. Vidra, how does exposure to racism and discrimination impact long-term mental health? Let's take us there. Oh, you on mute. You on mute.
I'm so glad you asked me that question because when she was answering, I was like, oh gosh, she made me think about something. And that whole question about, what mental health challenges disproportionately impact them. And then you say, how does racism affect? And the question to the answer to the last question for minorities is existence. Existing on earth as a brown person creates a disproportionate impact, right? Because you just have experiences that non-brown, colored, black, whatever you want to call it, people, they just, these are experiences they just do not have. And I'll just give you the example of how does racism affect you at work, right? Workplace for minorities is oftentimes a primary injury location. It's like a major site of mental injury. Minority workers have higher exposure to discrimination, microaggressions, job insecurity. They struggle with anxiety and depression, burnout. They feel like they have to overperform because, God forbid, they're seen as being lazy or not doing as much as everyone else. They have the emotional burden that they carry of trying to show up and smile and be present for everyone because everyone wants to see you looking pleasant. Because if you don't look pleasant, you may have an attitude problem. God forbid you be an angry Black woman or an angry Black man. Like there's so much pressure. And this is just at work, right? And then as a woman, we'll do that, minority. As a woman, you go through all the things that you go through, and then you walk outside and some man is looking at you talking about, baby, smile. It's like you're carrying you're carrying so many loads. And just because of the way that you look on the outside and what people believe about you, whether it is based in fact, stereotype, experience, or whatever, right? They are treating and operating with you in that way. And the actual impact of that, the trauma exposure of that, over and over and over again at the grocery store, while you're shopping, while you're walking down the street, while you're driving your car, the impact can be serious mental illness over time. We know that there are people who are predisposed to certain conditions, or well, not predisposed, but just have a higher likelihood of ending up with said diagnosis, right? Whether it's family history, whether it is the way that, the trajectory of their life and their experiences that they have had. And the impact of all of that then turns into depression with psychotic features. Maybe they then have bipolar disorder, an episode of mania. That's now you're bipolar type 1. There's there's so much. It has tentacles. It has tentacles. It starts with discomfort. It builds into stress. it turns into trauma responses. It changes your way of existing in the world. You become paranoid in some ways, right? Hypervigilant in others. It starts to look like PTSD. It just turns into other things.
Right.
And that is the impact of racism on our health, impacting blood pressure, impacting, dietary habits, impact how you're coping, right? Everybody's coping. We have positives and negatives. And so it's there's a lot. But yeah, those two questions, they were just like
Right. Thank you for that. Thank you for that. I want Miss Sinedra to lead us in the reflection and advice category. Okay. So, Miss Sinedra, what lessons have you learned working in minority health?
Um, so many, being that I am the minority, but health disparities are not accidental. They're predictable outcomes of systems that consistently fail certain communities. And I say that with regards to maternal health. For those who are new, I mentioned I'm working on my doctorate, and that's my subject. And I have that listed kind of at the beginning of my DMP project. The system fails minorities from the very beginning. It's what do they say? It's a scheme set up by Todd. That's what the young kids be saying. It's a scheme set up by Todd, i.e., the government. Whereas they think by giving us proximity, we should be able to flourish in a world that has every barrier at every turn to prevent us. So, how can I say this? The separate but equal that occurred during civil rights. We fought because we said that we should have the same rights as everyone else. We all bleed red, all the things. The government said, all right, fine, sure, we concede. We'll let you be equal to us. However, there's always that however. You have to do this, and this, and add 3 more of that to be equal. Meanwhile, our counterpoints just exist, right? And so the lessons that I've learned, and it took me a while. I've been in healthcare 24 years. And I'm at the point now in my career where I don't care. Even though I look young, I'm older. And so I'm like the social worker. I could tell you no with a straight face and a smile and send you on your way. Because now I have the experience and the education to back me on it, right? And it's disheartening when you have put forth that effort to be best as a Black woman. I'm gonna speak from my experience. I have the education, I have the experience, but then my counterpart has none of these things. And she gets the promotion. She gets the Atta Girl. She gets the Daisy Award, so forth and so on. I received a Daisy Award this year. This is my second one. I received one for leadership and one for being a nurse. Do you know that my charge nurse asked to see the person that not like the form or whatever for the person that nominated me because she just didn't feel like I deserved it? And she wanted to know what I did to be worthy of said award. Well, I actually saved that patient that day. You're welcome, because y'all almost gave him the wrong medication. So they thought that was important. But that hurt my feelings. I'm not even going to lie, because what do you mean you need to see the paperwork on something that a patient or a family member did anonymously based on how they felt I treated them or something they observed me doing? But the next person can receive the award just for saying, hi, thank you for visiting our hospital. I hope you heal properly and we'll see you next time. Well, not necessarily next time, but if you need to, we'll take care of you. Oh my gosh, she was so caring. Oh my goodness, she cared for me so much. I just have to give her an award. But meanwhile, ma'am, are you okay? Is there anything that I can get you? Do you need me to call your family member? Let me fluff your pillow. Let me change your linen. Let me get you something to eat. Let me go home and prepare it and bring it to you. Like, we have to do so many other things that are above our job description just to be regular. And that's unfortunate. The lessons that I've learned is to shine regardless. You are going to get all of this Black girl magic. You're going to get the smile. You're going to get the resting face, but you're going to get cared for. You're going to get advocated for. And I'm not going to allow any person, male, female, purple, green, yellow, to stop me from doing that, because that's the oath I took. So that's the lessons that I've learned.
Thank you for that. Now, Dr. Trish, what misconceptions do you believe commonly about health? Wait, what misconceptions do you feel that people commonly have about healthcare disparities overall?
I would say belief that minorities do not care about their health.
Okay.
I would also say over reliance on education without addressing systemic barriers.
Mm-hmm.
And I would also say the acceptance of resilience without institutional accountability.
I love that. I love that.
Yeah.
Miss Lou, what advice would you give to someone interested in a career in minority health advocacy? Being all the advocacy work that you do, what advice would you give a current student?
Be prepared to cry sometimes. But honestly, self-care.
Mhm.
Please take care of yourself. It's purposeful work.
Right.
Very, very purposeful. Do not get into this work if it's not something that you truly want to do. Please. And definitely take care of yourself. Take breaks, even if it's that, oh, I'm not I need to take a self-care day, put in a sick day or something. If you need to, send your kids off with grandma or with auntie or whomever, not whomever, please, not whomever, but a trusted family member. I gotta be careful. A trusted family member, please. And do some self-care. Take care of yourself. Don't overextend yourself to anybody. Have boundaries. Because this is definitely hard, purposeful work. So,
Miss San Angelo, yes.
I want to comment on someone in the audience. They asked Sarah Next Queen, how do I go about obtaining a healthcare advocate? I would say you would ask for a case manager or a social worker, but we have one on the panel, so I think that would be a good question for her.
Yeah, I think it depends on what system you're in. If it is just like your primary care physician, you want to find out if that's something that they offer. If it's at a hospital, obviously they have advocates at that hospital. You can request one no matter what. They have to provide you one by law. But then outside of that, people hire healthcare advocates all the time, particularly if they've been, if they've gotten a new diagnosis. I know that my practice worked with a woman this year. She was already like a therapy client, but she had a new diagnosis and she needed support kind of navigating and figuring out which system she was going to get her healthcare from, where she was going to go for her treatment. And then once she got set up with that system and decided which one, she ended up getting an advocate through them, and we're no longer providing that service. So if you are seeing a therapist or provider, sometimes they will support you in that and provide some clinical case management to you as well, as a part of the services that they're already offering.
And also remember to have them document. If you feel like you're being tossed around and you're not getting any results, make sure that that's documented in your chart. Because once you start saying, I'd like to see my chart, I'd like to request my medical records because I would like to get a second opinion or so forth and so on. They sometimes will change their tune because they know that you can advocate for yourself in that way. So verbiage such as, I would like to have this documented in my chart. I feel that I'm not being heard. Is there someone else that I can speak to? If it's a doctor's office, then, I would like to request a referral to see a different physician. If you're at the hospital, I would like to have my patient care advocate, so forth and so on like that.
Thank you for sharing that, and thank you for catching that, Mr. Niger. Can we drop subject matter expert in the chat? That's why they're all up here. We're gonna go on into the category of lived experience and community impact. We kind of already answered a couple, but I want Dr. Trish to answer this one. How do racism and discrimination show up in the everyday health experiences of the people you serve or you have served? It's a loaded one.
I would say microaggressions in healthcare and
Okay.
even professional settings.
Okay.
A need to like validate pain or symptoms repeatedly. And I'll give you an example within the nutrition fields.
Right.
Nutrition choices driven by access rather than knowledge.
Right.
And I would say reactive rather than preventative health behaviors.
Right. Right.
Yeah.
I love that. Thank you for sharing that, Dr. Trish. Miss Lou, how do poverty, housing instability, or food insecurity affect health outcomes in minority communities from your experience?
So how does poverty, food insecurity,
And housing instability affect health outcomes in minority communities from your overall experience?
so for me, what I see, if you're in poverty, and I know we mentioned a lot of this in the beginning, so sorry if I'm repeating anything, but this is definitely important. So poverty and food insecurity, it definitely have a direct and profound impact on health outcomes, especially in minority communities. So when people lack the access to consistent, nutritious food, it affects both your mental and your physical health. Physical health impacts diabetes. We talked about hypertension, heart disease. We talked about obesity. That is impactful when you don't have enough money to get the right nutritious food. And sometimes it's not even money, sometimes it's the education too, because you can create healthier meals. Because that was something that I've done when I worked for a hospital system, is create healthier meals for some of the patients, low budget meals, stuff that they can use with their, not only with their SNAP card, but with their WIC card as well. But lack of access to education, right? Mental health impacts, like worrying about when the next meal will come. If you're in poverty, that's hard, right? It causes stress, depression. It can even cause a lot of autoimmune diseases especially when you're a single mom, you're out here struggling, trying to make ends meet. That can definitely build up a lot of stress in your body and cause autoimmune diseases, cancer, developmental impacts. I have a best friend who is a librarian, and she calls my phone crying at least once a week because she works in a lower income community. And there's a lot of developmental impacts. So like children in food insecure households are more likely to experience cognitive delays, learning difficulties, behavioral health challenges, which can affect long-term outcomes, and then also like education. When you're in poverty, it's hard to, even have access to certain programs, right? Because when you're in a different neighborhood, I know I saw it because I went to I guess you can call it a PWI, a predominantly white institution high school.
Yep.
PW. And then I've also, and then for my last 3 years of high school, I went to a military school that was directly by where I live, which was in the projects in Chicago. But I saw just the difference, the food that was served, the programs, I was able to do cheer and all of those other things at the other school, at the predominantly white institution. But then when I came over to the military school, I just remember it just being a big difference. And yeah, so there's just a lot. There's lack of transportation without having a car, under-resourced neighborhoods, even with the roads, when you're seeing low resource neighborhoods where there's no money, right? there's not even roads to even run. And then you go to a high resource neighborhood. I don't know if this makes sense, but then you go to a high resource neighborhood and you see all the parks, all the pathways. Everybody's running with their dogs. It's just a complete difference. And that's what actually made me come into public health. Specifically because I was like, why is there a difference? Like, why did both of my grandparents pass away from diabetes, and why this could have been prevented? Why didn't they prevent this? What's happening? And then I realized, oh, my grandmother had schizophrenia. Okay, so that's, she just didn't get the right care. So it's just a whole bunch of things that was just going on in my mind. And I wanted to learn more in depth of like, why is this happening to people of color more than it is happening to our white counterparts? So yeah.
Right, thank you for sharing that. Next question for Ms. Davidra. What health issues are clients most concerned about versus what institutions prioritize? If your experience working with different agencies and different departments, I'm sure you can answer this well. I'll repeat it for you one more time. What health issues are clients most concerned about versus what institutions prioritize?
I mean, I think patients are worried about, can I function day to day if they have sleep issues, pain, anxiety, like, ability to go to work and show up on time, ability to manage their parenting responsibilities, right? And institutions are focusing on diagnoses, which is a deterrent for a lot of people. Their documentation thresholds, their billing. Can I code this? Because if I can't code the conversation you want me to have with your other provider, we're not going to be collaborating, right? I think patients are worried about like their mental health, their stress, their trauma, their burnout with work, with the communities that they live in. And institutions are just like, how many beds do we have? How many patients are in the waiting room? Let's fill them. Short inpatient stays because, we got to keep this thing churning, right? We don't want to keep them too long because we answer to an insurance company and they're prioritizing these, regulated 7 to 10 day treatment span models as opposed to actual improvement. That's not the standard of care. Stability, right? Patients want stability. They just want to be able to function. And that symptoms prioritize episodic illness because there are financial rewards in the episodic nature of treatment. The policies have been written in such a way that it ensures that that's the case, and that is the type of treatment you're going to get. And they're going to prioritize that type of treatment over longer term treatments and improved outcomes, or specialized treatments with longer lasting outcomes, because they are not financially rewarded for providing you those services.
Right. Makes sense. Okay, you nailed it. Dr. Trish, I want you to lead us in the solutions and the future section, okay? So, how can public health professionals ensure minority voices are included in decision making?
We have to tell our stories more. And we have to tell it to people that are listening and willing to hear, right? And that's ourselves. So we have to tell our stories to ourselves, because right here in this room, everybody that's in here, that number has not gone below, 25. It's been consistently at 25 and up, even a little bit over 30. So we have to be able to tell our stories to ourselves and listen and do something about it. I would say compensate community members for their expertise. Open doors, right? I mean, there has been so many shut doors in my career, but honestly, some I've even shut myself because I wasn't going to sell my soul to become director of blank, 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 blank. I was not going to sell my soul. So I stayed as a health educator. I went into teaching. I stayed with the community. I stayed doing what I am passionate about doing, right? So compensate community members that are working people in these institutions, in these facilities, in these schools, in these universities for their expertise and listen to them. Include minorities in leadership and advisory roles and work around their schedule and their life, be lifing, right? Don't kick them, don't kick the boot on them. And value qualitative stories alongside, of course, quantitative data that is coming really from the people, kind of like what health educator Luke has said. Go in the communities and do the work there with them. Do your work there with them and see really what is happening, because that's been my experience as well. And when you go into work in these institutions, into these hospitals, and you see a dissonance, question that, create programs, create funding to be able to, do work within the gap of all of that. There's a dissonance. There's definitely what we hear is not what we see, and we have to pay attention to that, and we have to be willing to listen to those that are at most, that are the most vulnerable. And it's us. Like I said, I started this conversation saying, hey, 9 ACEs. I have my doctorate in health education. I've been a health educator for 20 plus years. I'm an adjunct right now at a university. Do I want to become full-time? Not necessarily. Do I want to load on to that stress at 50 years old? No, I do not. I rather do little jobs here and there to make up for the bills I have to pay for. I have to take care of myself, right? So self-care, self-love. I am not young anymore and I can't go out and about, but I can still be a voice for others. And I'm trying to be a voice for others here as a TikTok live host that are looking for health and healing, right? That are looking for a healing process and, do what I can, but also know that there are certain things and certain circumstances, that I have to protect myself for in regards to. And I would say, we all have this and we have to all be okay to talk about it and, put attention to it and put focus to it, because we all have trauma. We all have something that we're dealing with. We all have, these systemic things that are over our head, and we're all just trying to also, in a sense, survive and get ahead. And so just be open about it and just talk about it and just listen to each other.
Right. I love that. Mr. Najra, what changes would you prioritize if resources were unlimited? Unlimited.
First and foremost, universal health care for all, without a doubt. Stable housing. I wanted to piggyback on the previous conversation. You guys mentioned all of the things I would have said, but I wanted to add the unhoused. The unhoused is the forgotten community of minority. I mean, they're comprised of all demographics, but there's a large population, especially in California, of minorities that are unhoused. Now, I can get into the semantics of why we as Californians, and I'm not a native, but I live here, feel that we're being dumped on because we're learning that a lot of our unhoused citizens are coming from other states, but at the end of the day, they're still unhoused and they need a lot of medical care that they're not getting. And so I just wanted to add that into the previous conversation, that the unhoused is a demographic of people that need to also be in that conversation. But if money were no object, everyone would have a place to stay. All their bills would be paid. We would have education for all. There wouldn't be any food insecurities. Everyone would have a grocery store or a community garden. I think we should go back to, I wouldn't say the way of life because it wasn't for everyone. I grew up in Louisiana, so farms were kind of a cultural norm in that area. So I can't speak for like other states, but I do appreciate that a lot of communities are starting to do that co-op thing where they're being able to provide for their specific area with regards to bartering with food and stuff like that. So making sure we have stable housing, food security, culturally responsiveness, and having culturally responsive services. Specifically in healthcare, I can't tell you how many times we've had someone that speaks a different type of Asian language that may or may not be on the interpreter list. Even though we have the iPads, they don't always work, or they speak a more formal language than what that person has learned. We have a high Mexican population, for example. And so they have their Mexican slang, which is different from Spanish, just, the regular. I don't want to say the king or queen Spanish, like we have the queen's English, like I don't know what that would equate to for Hispanics, right? But their formal version of Spanish is different than what they've learned in their Mexican culture. So we sometimes have that barrier with language, and we have a lot of Asian, a large Asian population here in California. So that's one of the things that I find, if money were no option, we would have all the interpreters, whether they're on an iPad, a telephone, or someone who is a polyglot and speaks multiple languages, because I could see the fear in their face when they're having to come for surgery and we're trying to explain to them their consent form, and the consent form is in English or Spanish. We don't have other languages. And what if they speak French, or, what if they speak something else? And they are working on getting it where we can print it in their language, but you're supposed to have the interpreter read line for line and say it in their language so that they understand before they sign it. And while it works, it still doesn't work, if that makes any sense, because they still have questions after they've spoken to the interpreter. The machine is now turned off, and I'm having to use my phone with the Google Translate to have a conversation to make sure that they fully understand. So that's really important to me, that we have that type of cultural responsive department. I don't know if we could create that. That should be a department. I don't know, like a language department or something, where we have the advocates from different origins as well as the language speakers. And preventative community care. At the end of the day, it goes back to education. If money is no option, then we should be able to have the education for our communities. Teaching how, if you are pro-vaccine and or not, the pros and the cons to it, making sure that our preschoolers are ready to go to kindergarten, making sure that everyone is meeting the metrics that they need for their weight. I forget what it's called when, they go to the pediatrician and there's the different landmarks and milestones that they need to meet. That's very important. And that also goes back to them having the food necessary for growth. Making sure that our middle schoolers, our elementary school, high schoolers, up till college, they have the educational resources they need. There's no reason why students should be reading out of an outdated history book or English book when the other schools have the new and improved updated version of said book. So if money were no object, we would have all the things we need.
Thank you for that.
And we would also, one last thing. We would also have updated technology. Our beds and stretchers would work. The phones would work. The computers and laptops would work, and the Wi-Fi would be, it would work, Lord. It would work. Okay, I'm sorry, I'm off my soapbox.
Thank you for all those are great ideas. Thank you for sharing those. The mogul social worker, we've come to our last question. You guys did an amazing job, okay? We've come to our last question, and the mogul social worker is going to take it away. But just to prepare the others, I'm going to have each of you share your overall why. Okay, so as the mogul social worker is taking us away on this last question, prepare your overall why. Okay, so the mogul social worker, last question. How can students or young professionals contribute to reducing health disparities overall?
So I'm going to cheat real quick. I got
That's
one thing to add to her last one.
Sure, go ahead.
To treat workplaces as public health partners.
Okay.
That we need to train managers differently, that we have employee assistance programs that these companies are paying for, and they are just stealing their money because they're barely offering any services, and really they need to function.
We would have to go offline on that one because
Okay,
there's
that's
an
a whole
expose
other thing.
on that one, girl.
Maybe
They
a
scared to
whole other
use it
thing.
because they're using it to get them fired.
And that's my point, that EAP needs to function as a feedback loop as well for leadership, so that when you see patterns of issues showing up in the workplace that are clearly impacting employees' well-being, that is then being responded to, because the feedback, everybody ain't lying, right? We know we have some toxic leaders out here. We know we have some toxic workplaces. And so they need to be a part of that process. But also, in a perfect world, if we had all the resources, my government would ensure that every child who has a guardian, parent, caregiver who is responsible for them, that individual will be in their school, would be in their school for the entire school day, at least one day a school year, that these schools would have parents present to support them, that there would be adult presence at all times, that the supervision would be maximized so you don't have students getting raped in the hallways under the stairs, so that because there's so many other issues that are happening that our labor force, our labor processes do not support our ability as parents, as children, as siblings, to support our family members. So that's the only thing that I would add to that. But what can the babies do to help? Dr. Tish said something about not selling her soul for that director position over there. And girl, I agree. But what I want these babies to know is we still need y'all to take some of these jobs. I took a job working for Satan and the only standalone psychiatric hospital in the District of Columbia. I knew she was Satan in the job interview. Do you understand me? Mm-hmm. But what I also knew when I was meeting Satan was I can only imagine how she running this hospital. Okay.
Was she with MedStar? Because listen.
No, she was with Universal Health Services, a conglomerate that owns hundreds of hospitals. Okay. And she had been let go from a hospital in Massachusetts because of a death that happened there at a psychiatric facility. But of course, they brought her down to DC, an area that is, I know it's known for being Chocolate City. And we know that, the demographics have shifted a bit. But DC is run by mostly Black men and women in local government. Okay. And she was operating in this hospital in a way that Dr. Tish is talking about. I'm not trying to sell my soul for this company's profits. Right? But we need these babies to take these jobs when you come out of school and when you get in the world and you have these opportunities. We need you to take these jobs because y'all are at the right age and stage in your career to take one for the team. I took one for the team. I went in, I made as much change, I balked as much as I could and said no as much as I could to the things that were wrong. I made connections with the local community. I changed our image with the local hospitals and the Department of Health and Behavioral Health that did not want to engage with her, right? We have to be there. We got to show up, right? So we can make things better for the minorities that are coming into these systems. Now, eventually, they're going to want you to do something that's probably going to be illegal. Okay. And you're going to have to leave. Right? But the change that you can create in these systems when you get there, that's the stuff that the workers hold on to. That's the stuff that they keep doing. That's the stuff that changes outcomes for the patients, right? And then next, we need y'all to run for office.
Hello.
If we are not out here, and that's local, that's state, that's federal. If we are not out here in power positions teaching our counterparts how to be in community, because a part of being a minority in this space is they have wanted us to assimilate so much that so many of us have, even in our educations, and we have forgotten how our communities existed prior to them. So we need to get back to community. We need to get back to teaching our children how to foster and create community so that when they come out of schools, they can get into these systems and create the communities in these corporations, but also in the communities in which they are raping and pillaging of resources and then underpaying the people who live in it, or not employing them at all and moving them out so they can move in the people that they prefer to employ. We have to put ourselves in these spaces more and more and more and more and more. We have to start owning these companies. Why is the MBA owning the clinic? Why is the accountant owning the healthcare facility?
Right.
And not the group of nurse practitioners that got together and put this business together, not the group of behavioral health clinicians who put this practice together, right? We have to take over. That's the only way this changes.
And also, if I could just piggyback on the unlimited resources, can the healthcare people get a raise in our unlimited resource of money, Father God?
Wow.
Everybody would get a raise if I had the blank check, just so y'all know. We would be paid what we're worth. No, we're not going to, empty out the bank account, although we're worth it, but paid what we're worth, not what they're saying we should have. Meanwhile, the CEO gets $20 million as a bonus. Like, make it make sense. Pay us what we're worth. Okay, sorry.
No, that was perfect timing. Thank you so much. Well, you ladies did an amazing job. I want to thank you guys for your time. Thank you for being here. Thank you for being a part of this important discussion. First up, health educator Lou, can you share with us your overall why as it relates to the work that you do and why you continue to show up?
So my why is rooted in really purpose. So my why is to live intentionally and purposely, to step into work that matters not just for today, but for future generations to come. So I'm not just living for today, I'm living for the future generations to come, for my children's children, right? Helping people heal, grow, and thrive because their health and wellness matters, especially people of color who've experienced a lot of trauma, a lot of systemic racism, all of that. Like, you matter, we matter, right? Every breakthrough, every step forward, it sends ripples through families and communities, because I know it sent ripples through me when because what inspired me, not only my experiences, but I also had someone that was rooting for me, one of my teachers, right? So please advocate. That's one thing too. Please advocate. If you see someone that has potential, or even if they don't have potential and they need help, because you can definitely be their breakthrough. So that was just a side note. But my work goes deeper than that. It's about breaking the systems that were designed to hold us back, to limit our potential, and really just to perpetrate, really overall trauma. So I show up to create space for healing, to disrupt cycles, and to stand for a future where wellness, opportunity, and purpose are not privileges. They are rights. And my purpose is inseparable from the growth and the liberation of others as well. So I'm definitely, my why is just rooted in a lot of purpose and generational healing.
I love that. Thank you so much for sharing that, Miss Sinadra. Your overall why as it relates to you continuing to show up.
Okay, so I ironically have this written down, so I'm just going to read my little snippet of my why. I had it from my vision board. My why is rooted in my lived experience as a nurse, a leader, a mother, a wife, and a Black woman who has seen firsthand how systems have failed the very communities that they're meant to serve. I've spent over 2 decades at the bedside and in leadership watching preventable harm happen because of bias, lack of access, and policies that ignore the realities of marginalized families. I do this work to be a difference, not just for my patients, but for my community and my family. I want my children and my future generations to inherit systems that protect them, listen to them, and value their lives. I advocate because I have seen what happens when voices go unheard, and I refuse to accept that inequity, that inequity is inevitable. My why is about accountability, access, and dignity. It is about building a pathway to care and amplifying community voices, and using my position to challenge systems that produce these disparities. This work is personal, it's purposeful, and it's non-negotiable because my community deserves better, and I am committed to being a part of that change.
I love that. Thank you so much. Dr. Trish, your overall why. Why do you continue to show up? Why do you continue to do the great work that you do?
I would say that my why has been evolutionary. 50 years old today. So my why back then was because
Happy birthday, Dr. Trish.
oh no, I'm not 50 years old today.
Oh, you said that.
I'm 50
Oh,
years old.
okay.
That was funny.
Oh my gosh.
I'm 50 years old.
Okay.
Hold off until April 10th, Dr. Johnson.
No, okay, yes, ma'am.
But what I'm trying to say is, back then my why was my mom. My mom passed away from metastasized breast cancer. She was a very religious woman. And again, bittersweet because her prayers went very far, where it's touched my life and it has completely transformed it over. So those prayers are not in vain, mommy. But she was struck by advanced metastasized cancer. And so I became a health educator so the same would not happen, right, to other Latinos, brown skin minority women. And I worked really hard and long, tirelessly for many, many years, being the voice for patients, for my patients, my clients at the time, the people that I served, the families that I served. After that, my why became more about education. And because it's powerful, it's impactful, it changes lives. Having a sense of awareness, seeing things taking place, observing, learning, attaining wisdom, doing differently, going about things differently, learning how to continue to evolve in your education, have it be its professional, professional, what is that? Development or personal development. And most recently, my why has changed too because we have a lot of things that we're dealing with and the odds are against us. And so we have to take things into our own matter. And we have to seek for our own health and well-being. And for those parts that we need help and we can't find the help, well, I got an ultimate helper for you that will help you. And he will show up. And that is the Lord Jesus Christ. Amen. So that is my why. There is healing. There is health. There is wellness to be attained. There is education. There's empowerment. There's inspiration. There's resilience. Okay. There is all of that. But we have to have the will. We have to have the will to do the hard work for ourselves and our families and our children and our children's children. And that is my why.
Amen. Thank you for that. The mogul social worker, your overall why. Why do you continue to show up? Why do you continue to do the work that you do?
I'm glad Dr. Tish brought up Christ because the reality is I came here with the heart of a social worker. Mm-hmm. I have had that heart my entire life. I was a social worker in kindergarten. And I'm allergic to oppression. It just does not sit right in my spirit. And so I cannot live a peaceful life watching people around me be oppressed. There is no joy, there is no happiness, there is no forward momentum in this life for me if I am not helping people achieve whatever it is that they need to achieve, right? Like, that is my purpose in this world. And that is not something I've ever questioned, not something I've ever not known. It was is the corniest thing in the world to say, but it was a dream of mine to become a social worker. I was terrified, and there were a lot of roadblocks along the way. But the very first day of grad school, as I was walking to my little orientation, I distinctly remember thinking, like, oh my God, all these key moments in my life where I was like, I'm gonna get it, I'm gonna do it, I'm gonna do it. And I did not do it in the timeline I would have wanted, but I knew I needed those letters behind my name in order to be able to help people in the way that I wanted to be able to help them. And that was what it was for, right? That's what the student loan debt is for. I'm paying debt. I'm paying debt so that I can live my purpose and help others. And so my why is always going to be fulfilling the mission that God sent me here for. And all I know of it to be is to help others.
Right. I love that. Ladies, once again, thank you so much for taking the time to participate in this important conversation. I appreciate each and every one of you, and I love the work that you guys are doing, and I love the content that you guys are posting on here, and that's why I invited each of you to come and speak on this important topic. So before I drop these ladies down, can we drop some subject matter experts and some thank yous in the chat? Can we drop some subject matter experts and some thank yous in the chat for their time, because they did an amazing job, okay? And we stayed on for over 2 hours. Can we drop some thank yous and some subject matter experts, okay? And we tell them thank you, and we drop you some deuces. So once again, ladies, thank you so much. You were amazing. Health Educator Lou, the Mobile Social Worker, First Class RN, Dr. Trish, thank you so much. Thank you so much. And okay, I see you guys in the chat, and thank you so much for the work that you guys do, okay? Deuces, can we get a deuces? Let me drop y'all down. Straight jeans, cut off footpaths. Everybody have the arms when me get my class. Everybody have the arms when me get my class. Real bad man, no model in a shots. Straight jeans, cut off footpaths. Everybody have the arms when me get my class. Everybody have the arms when me get my class. Everybody, yes, lots of gems. So everybody, thank you so much for sticking around. I will be posting the conference later on. You know where I'm posting it, over on YT. Once again, thank you so much for being here. Thank you so much for showing up, and thank you so much for engaging and being a part of this important conference, okay? This was Minorities in America, a public health issue. Thank you so much. So good. Thank you so much, you guys. Have a good night. I'm going to see y'all next Tuesday. Okay, next Tuesday. Deuces, y'all.